Hello and welcome to today's webinar, Implementing Tech-Enabled Innovation in Medicaid Managed Care, Opportunities to Advance Health Equity and Quality, made possible by the MolinaCares Accord, CommonSpirit Health, and HopeLab. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. There will be a moderated question and answer session during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. A brief online evaluation will pop up on your screen following today's event. Your feedback is very important to us, and we hope that you'll take a moment to complete this survey. I will now turn the webinar over to Kelsey Breichman, Senior Program Officer at the Center for Healthcare Strategies.
Thank you, Travis, and welcome everyone. I'm so glad you can join us for today's event. Healthcare organizations increasingly leverage technology-enabled innovation to improve quality and enhance access to care. As technology becomes increasingly widespread, it's important for states and health plans to ensure that Medicaid populations have equitable access to beneficial technologies available to commercial and Medicare populations. I'm excited to facilitate today's conversation, along with my colleague, Carissa Godzik, Program Manager at the Medicaid Innovation Collaborative. The objectives of today's webinar are: 1, exploring the opportunity of tech solutions to improve care for Medicaid populations, and 2, exploring how Medicaid agencies and managed care plans can support innovation. Next slide, please. For those of you who aren't familiar, I wanted to briefly provide some background on the Center for Healthcare Strategies. CHCS is a policy design and implementation partner dedicated to strengthening the U.S. healthcare system to support high quality and equitable care, particularly for people served by Medicaid. Of particular relevance to today's event, CHCS is currently participating as a partner in the Medicaid Innovation Collaborative, an initiative aimed at supporting adoption of tech innovation within Medicaid. Next slide. For our agenda, we'll first provide some contextual remarks to ground today's conversation. Then, the majority of the event will consist of a panel discussion featuring representatives from Medicaid agency, plan, and health tech perspectives, followed by audience Q&A. And now, I'll pass it to Carissa Godzik to provide some additional context on the focus of our event. Welcome, Carissa.
Thank you so much, Kelsey, and thanks everyone for joining us today. We can jump to the next slide. So what do we mean when we say tech-enabled innovation? I'm sure if we polled the audience today and asked what innovation meant to all of you, we'd likely get a good variety of responses. So often innovation can be one of those amorphous buzzwords that gets thrown around a lot. And you can see a couple of the ways the kind of tech-enabled innovation that we're interested in is described around the edges of the slide. But in our case, we define innovation by a couple of key components. First, the purpose of innovation is to address the needs or wants of a customer, or for some of you on the webinar today, a client, a patient, or a member. Second, it's primarily driven by a desire to make something better. In the case of the Medicaid Innovation Collaborative, we're interested in enhancing care, and this could be access to care, quality of care, or the coordination of care for better health outcomes. This can mean working within or outside of the traditional systems of care. And of course, innovation implies that there is something new or novel about the approach. It's also incredibly important that the product or service has longevity, that it can scale and sustain over time, and that it delivers value to the intended customer, and ideally to the broader ecosystem as well. And finally, the tech-enabled piece of this simply means that an innovation harnesses existing technology to deliver a product or service. For instance, a smartphone app. Some innovation might be high-tech, low-touch. Some might be low-tech, high-touch, and then there's everything in between. Next slide. So for us, it's really about assessing the landscape to think about how tech-enabled innovation might tackle some of the biggest health equity concerns of today. How might tech-enabled innovation address determinants of health? How might it take on the very challenging task of meaningfully engaging members? How might innovation enhance maternity care in order to reduce maternal mortality for Black birthing people in the US? And it's important to note here that while we've included a number of organizations that are working on these kinds of challenges today, this is really just a small snippet of a much larger market that we know is growing and evolving. A remaining challenge, though, lies in who these solutions are built for. We do find historically tech doesn't typically focus on Medicaid. Rather than health tech, it's more like wealth tech, as a colleague of mine likes to describe. They're built for employer-sponsored commercial members. And Medicaid can be a tough market to break into. The ecosystem is relatively fragmented, state by state, payer by payer, and the populations are known to be harder to reach. Next slide. So why work to integrate tech-enabled innovation into Medicaid? We believe there is immense potential for making care more equitable, not only between Medicaid and commercial populations, but within Medicaid, across lines of race and ethnicity, gender, geography, etc. Tech-enabled innovation can fill gaps where traditional systems of care may fall short or be under-resourced, and in doing so can improve all those dimensions of care: access, delivery, quality, and coordination. Tech-enabled innovation can address disparities in care or outcomes by providing a new approach that may better serve a population's needs or preferences. Tech-enabled innovation can be more responsive to the needs of populations. They're built to be iterative and adaptive and employ principles of human-centered research and design to be proactive rather than reactive to customers' needs. Tech-enabled innovation can be the needle and thread to connect and weave together disparate resources, which in our case is the wide array of health and social service organizations that serve Medicaid beneficiaries today. And with more frequent touch points with patients or members and improved engagement, tech-enabled innovation is equipped to capture regular data on users' physical and mental health, as well as their environmental or social needs. And so what we see in solutions that are successful in working with Medicaid is that they are usually built with and for the intended users. They acknowledge and help bridge the digital divide through considering things like bandwidth constraints and digital literacy. And they are creating culturally responsive offerings and often are considerate of patient-provider concordance. And so where does the Medicaid Innovation Collaborative fit into all of this? Next slide. MIC, as we like to call it, is focused on advancing health equity and improving outcomes for Medicaid beneficiaries by partnering with state Medicaid agencies, their managed care plans, and community members, including beneficiaries themselves, as well as health and social service providers, to identify, source, and implement exactly the kind of tech innovations we are discussing today. Next slide. We do that by running a 15-month cohort program where we define and align on a health equity priority, complete primary and secondary research to understand that priority and how it manifests in our cohort states. We source innovative solutions through national RFI, evaluate and select the most high impact aligned innovations, and support the adoption and implementation of those solutions. Throughout the program, cohort participants get to collaborate with each other, and our state Medicaid agencies receive technical assistance from our partners at the Center for Healthcare Strategies to understand policy changes that might support managed care plans in contracting with innovative solutions. If you have questions, I encourage you to check out MedicaidCollaborative.org, where you can learn more about our first cohort, which is just wrapping up. And with that, I will turn it back over to Kelsey.
Thank you so much, Carissa. Next slide. And yes, next one after that. Perfect. So with that, I'm going to transition into today's panel discussion. I'm really excited to introduce Cindy Bean, Heidi Eccleston, and Abner Mason. Cindy Bean is the Commissioner for the West Virginia Bureau for Medical Services. During her time as Commissioner, Ms. Bean led policy implementation changes under the Affordable Care Act to expand access to care. She has led initiatives such as obtaining coverage for neonatal abstinence centers, developed waivers to support treatment of substance use disorders, and implemented health home initiatives to improve outcomes for individuals with chronic conditions. Ms. Bean has over 20 years of experience working with healthcare in both public and private sectors and has been named President-elect for the National Association of Medicaid Directors for 2023. Heidi Eccleston is the Senior Director of Program Development at Banner University Health Plan. She brings over 20 years of experience working in various healthcare settings in Arizona, Utah, Florida, including clinical program development, healthcare leadership, and extensive knowledge of both operations and the behavioral health system. During her career, she's written and presented on 3 successful requests for proposals through the Arizona Medicaid Procurement Office and implemented one of the first integrated serious mental illness plans in Arizona. She has extensive experience managing care for both Medicaid and Medicare recipients, ensuring they receive quality care. And finally, excited to introduce Abner Mason, who is a leader in driving health equity. As the founder and CEO of Same Sky Health, he leads a diverse team of professionals who strive to improve outcomes and lower costs on behalf of health plans. Previously, he served on President Bush's Advisory Council on HIV/AIDS, as Chief Policy Advisor to the Governor of Massachusetts, and as part of the Biden-Harris Campaign Policy Committee. He currently sits on the boards of Manifest MedX and the California Black Health Network, is a member of the United States of CARE's Founders Council and the AMA's External Equity and Innovation Advisory Group. He is also the founder of Health Tech for Medicaid. Additionally, each of our panelists has been involved in the Medicaid Innovation Collaborative. Ms. Bean and Ms. Eggleston were participants in our first cohort focusing on behavioral health innovations, and Mr. Mason is an MIC advisory board member. During our panel, they'll draw both from experiences with MIC and their broader work. So with that, welcome everyone, and I invite you to turn on your cameras. Great, hello. So I'd love to kick off our discussion today by hearing from each of you about what makes you excited about the role of tech-enabled innovation and Medicaid care delivery transformation. What do you see as the key opportunities for tech-enabled solutions to overcome health system challenges? And let's start with Cindy.
Well, first of all, thank you. And what a pleasure it's been to be involved in this cohort. And the possibilities are really endless. Medicaid, I feel like, is an untapped market with regards to tech-enabled solutions, but it's a market ripe for a tech-enabled solution. We do know that even with things like the unwind and things that are coming up, cell phones and keeping track of our membership and member engagement is something on the Medicaid side we've always struggled with. There are always some patients that we have that are more transient than others, have different challenges than others. And so tech is really a way for us to be able to keep those members engaged. So there are a variety of solutions with regards to assessments, member engagement, different telehealth options as well. But I really feel that member engagement is a huge untapped area for a tech-enabled solution for the Medicaid population. And I think with this kind of tapping the surface, I think it's going to go far beyond.
Thank you, Cindy. Perhaps Heidi, let's turn it over to you next.
Yes, thank you. I piggyback off of what I'm really excited to really increase and improve access to care. I think this is a great opportunity, especially when we're looking at such workforce challenges. This is really a way to address some of those needs thoughtfully. One of the, what I get excited about is, really looking at platforms and solutions that can not only improve access to care, but really that real-time coordination and handoffs, which is key when you're looking at and assessing whole health across the healthcare delivery system, and various e-consult platforms. Also addressing gaps in HEDIS measures is a great way to push data out to members to really ensure that they understand some of the, care coverage gaps that they have, and addressing those and really getting information out to members. And to piggyback too off of what Cindy said with the unwind, yes, we are, looking at how we can push that information out to reach a larger population. And I think those are some of the things that I am excited about to really move the system forward.
Thank you. Abner.
Great, and thanks. It's great to be here, and honored to join Cindy and Heidi, who are both leaders and doing great work. So it's great to join you. I agree with their comments. One thing I'm particularly excited about is the opportunity that tech-enabled services gives us to have a better, more personalized relationship with the patient or the health plan member. I think in the past and currently, frankly, healthcare is still kind of a one-size-fits-all. We have not in healthcare moved to create a more personalized, customized experience for every patient and every health plan member. The rest of our economy has moved toward that personalization. You know, I would suggest, look at Netflix if you use Netflix, or Amazon if you buy something. It doesn't take very many interactions with Amazon, or, transactions, or very many selections with Netflix before they start to personalize the experience for you. They don't treat Cindy like me. They recognize that we're different. We have a different life journey, different history, different levels of different experiences completely. We're just different people. In healthcare, we haven't gotten there yet. We're still kind of stuck in this, frankly, in the 70s in the way that we engage the patient or the health plan member. And I think one of the biggest things that technology is going to enable us to do going forward, and I'm really excited about that, is to personalize the experience. And I think that as we personalize the experience and actually treat people like who they are matters, we're going to build trust, more trust. And I think that's one of the things that's missing in healthcare. So Cindy said big opportunities. I totally agree. Big opportunities going forward. And the only way we're going to do that, the only way you can create a personalized experience, for example, for millions of people, is to use technology. So I'm excited about what we can do there.
Great. Thank you all for those opening remarks. So building off of these ideas, I'd really love to delve deeper into how each of you are working to leverage tech to meet quality and health equity goals. So this time, let's start with Heidi. What types of tech-enabled innovation has your organization implemented to date? And are there types of innovations you see as particularly promising going forward?
Sure, thank you. There's a couple I want to touch on that we've implemented. One is the Pix phone app. It is an application that addresses loneliness and isolation, and it came about a great time, obviously, when the pandemic hit, to really push this out to our membership, both. And for us, we serve both Medicaid as well as Medicare members, as well as the long-term care folks. So we use this application for all of our lines of business. And really, it is a check-in app. It provides pre and post kind of where a member is sitting when they first get on that app, and where they're at various intervals throughout the time that they are engaged with that application, to really measure, how they're feeling at the end of an engagement. And one of the nice things too is not only is it just an application, but if a member is displaying warning signs through some of the questionnaires or check-ins, there is a live agent that can reach out to that member and ask, do you want to talk to a live person? Or the member maybe is not doing well and they want to request somebody to give them a call. So they kind of have both of that live person interaction as well as the applications, just to kind of go through different modules, different coping skills, as well as they do address SDOH, which is a key component of our membership. And if a member says, that they have food insecurities, they can send them community-based resources that are right in their community that reach out to get those needs met. And we've seen a successful outreach, like we've seen a 36% reduction in loneliness and a 43% reduction in depression. At any given time, we have a little over 4,000 members on that application. So that one we've been up and running for many years now on that one. The other one I just want to touch on real quick is we just implemented RoviCare on the beginning of this year, and that is a centralized referral system. We're currently using it for attendant care for our Altex population. So prior to RoviCare, you would send numerous packets in paper and fax it out to all of the providers and wait to see who's going to accept the patient. So this way, it's a centralized platform. All the attendant care providers are on that platform. They get the referral, and then they can click and say, yes, we have the services in that area. We can go and start services. And really also besides improving access to care along that line, it also lets us monitor providers so we can really see who's consistently denying or not accepting a patient and who consistently is meeting the needs of some very complex members.
Great, thank you, Heidi. And I got a question in the chat related to what you were saying, asking about the app name. PYX, I believe that's what you said?
Yes, it's a PYX.
Thank you. Okay. So turning to Cindy, similar question for you. Would love to hear about what West Virginia's goals are for tech-enabled solution adoption. And again, what you see as particularly promising.
Yeah, so our MIG project really focused on adolescent behavioral health. With COVID and everything that's going on. We saw a huge increase in need with adolescent behavioral health. So one of the things that we did was have a variety with the project's help, of course, of vendors come in and present to our MCOs. And one of the things we're doing is requiring the MCO, not dictating, which app, whether it be PYX or something else that they utilize, but requiring a tech-enabled solution for them to help with this area. But it really does go beyond that. As I was listening to Heidi, I was thinking, oh gosh, that sounds like great. The referral for her long LTSS services, like we really need that in West Virginia. But right now that was our current focus. But there are so many needs that we have. We wanted to start there. And then our MCAs do have some tech-enabled solution, but we thought it would be really unique to have them all focus on one particular problem, use a tech-enabled solution, see how that basically pushes the ball forward by using that solution, because we all know that there's a huge workforce crisis out there. So we need to kind of think out of the box, think inventively of how to address some of these real needs that the pandemic has caused at the same time that you have the workforce issue. So in order to do that, not only are we working collaborative, but we will make it a requirement in their RFPs and contracts. So while it is collaborative, it is also, you will do it as the Medicaid director.
Thank you for sharing. And so now for Abner, kind of approaching from a different perspective, would love to hear what your experiences are working with plans and states to help meet quality and equity priorities. And just more broadly, how can tech organizations really be a partner in this work?
Sure. So thanks for the question. I think one of the areas that we are working in that is just really I'd say it's fair to say exploding in terms of interest, and it's super exciting, and I think it's a good thing for our healthcare system and for our country. A lot of people outside of healthcare don't realize this, but up until now, health plans, for example, have not been required to collect race and ethnicity and language data on their members, or sexual orientation or gender identity data on their members, or social determinants of health data on their members. And if you just think about it, if you don't know those things about a person, it's hard to even think about providing high quality care, right? If you don't know someone's gender orientation, for example, or the language they prefer to speak in, or race. And so what has happened recently is that regulators at the federal and the state level, for a whole host of reasons, have come together, and they are requiring plans for the first time in our nation's history to collect race and ethnicity data and language data, and in the next few years, SOGI, sexual orientation, gender identity data, and even starting now, social determinants of health data for their members and patients. This is an enormous opportunity for us to make our healthcare system more equitable, because we all know our healthcare system is not equitable today. It does not work well for everyone, or the same for everyone, and especially for low income, low health literacy, people who, because of the social determinants of health, meaning they're poor, they struggle to connect with healthcare. Our healthcare system just doesn't work well for them. And one of the only ways we're going to, I think, move forward as a country and create a more equitable system is, one, we have to know where the problem is. Two, we have to be able to measure the problem. We need metrics, and then we need to target solutions at those disparities once we can put data around them. And that's what this new requirement from the federal government, and the states are doing it. They're requiring that the plans to collect this data enormous opportunity for our healthcare system, and I am personally really excited about what it could mean going forward for the reasons I just discussed. But to do this for a country of over 300 million people, a Medicaid program with 75, 80 million people, to get people to share with you some of this information. The only way you're going to know someone's sexual orientation is they've got to self-report. They've got to tell you that. There's just no other way to know. And you need to build trust with people so they'll share, self-report that information. And this is where technology comes in. I know my company is focused on this, Same Sky Health. We are partnering with health plans across the country to help them to build a more trusted relationship with the member and to collect this kind of information. But collect means you've got to build trust with that member, and they tell you. You can't make them tell you. And so you can't even make people tell you what the social determinants of health that impact them. You can't make someone tell you they don't have any fruit in the refrigerator. They've got to trust you enough that they share that information with you. And so what we're doing is we're using, a sort of culture first approach to build that personalized relationship. So one, the regulation, and I love what Cindy just said, these aren't nice to haves. You've got to do this. And so this is regulators have come together for the first time in our country's history, and I think it's great. They are saying you have to do it. And I think technology solutions like my company, but I'm sure there are others, need to partner with health plans and help them to do this. And as we begin this health equity journey, which it's not going to happen in a year, it's not going to happen in 2 years. We're talking a 5 to 10 year journey that we're on. Tech-enabled, partners are going to be key to partnering with health plans and helping them to do something they've never done before, frankly didn't want to do, but we are where we are now. And the wonderful thing now is that all the stars are aligned in a good way. So that's one of the key things that I'm seeing that's different. And I want to give NCQA a shout out because they are part of this. They're not an actual regulator, but they partner with the regulators, and they're requiring states. They've got a new health equity accreditation, and states are partnering with them. They're requiring, states are saying MCOs who work in their state have to do this and have to report quality measures, HEDIS measures stratified by race and ethnicity. And think about that. Plans didn't even used to collect the data. Now they have to collect it, but they have to report quality measures stratified by race and ethnicity. This is the direction the country should be going. It's a good thing. It's hard work. It's not going to be easy, but it's where we are. It's what we ought to be doing.
Thank you so much for those thoughts. So, yeah, really great just to hear from kind of, since you all work for different types of organizations, really great to get that kind of wide range of perspectives. For my next question, I want to shift the conversation a little bit more towards the direction of implementation. From each of your perspectives, I'd love to hear what you see as factors that are either enablers or barriers for implementing tech-enabled solutions for the Medicaid population. Abner, let's have you start with this one. Oh, you're on mute.
Sorry about that. Yeah, so thanks for the question. I'd say, one of the things that people who know me know that this is something I've been talking about for a long time, and we still haven't fixed it. And that is, we have antiquated policies and laws that are preventing us from doing what we know is the right thing to do. So today, Medicaid populations, like the rest of America, if you ask people how they communicate, they will tell you it's text messaging, or they won't say US mail. If you ask people, how do you communicate with your family and friends? I guarantee you people will not say, well, my primary mode of communication with family, friends, and even colleagues is letters. They don't even say email. They will, by 10 to 1, they'll say text messaging. And yet today in America, Medicaid managed care plans are unable or really constrained. So they're somewhere between, unable in their minds and constrained in using text messaging to communicate with the members, even though that is the way the members prefer. That's what they want, and sometimes it's the only way they're going to communicate. It's 2022, and we're living with a law that was passed in like 1992. It's a federal law called the Telephone Consumer Protection Act, and it's a darn shame. It's just, to me, it's scandalous that we haven't figured out a way to fix this and to allow Medicaid managed care plans and other healthcare stakeholders too to communicate with their members via text message without constraint. Interestingly, we talk a lot about the unwinding or the redetermination process that's going to happen once the public health emergency comes to an end. And there's some good news here that CMS and HHS have gotten together and they've talked to FCC, and I know that's a lot of acronyms, but basically the federal government has gotten together and said, maybe since we've got 15 million people that we need to reach out to very quickly, and the only way we're going to do that really practically is using text messaging, they're trying to carve out, an exception to allow plans only for the purposes of redetermination to use text messaging. So first of all, good news. Thank you, CMS, and thank you, HHS. But the fact that we've got to have an exception in 2022, just because of the end of the PHE, we're going to say that, okay, you can text your members. It's just, come on, we as a country can do better. So if you ask me what's preventing, that's one example. I've got a lot of others, but I don't want to take up too much time, but that's one that is so glaring. We need to fix this, and we need to fix it now.
Thank you. Let's see here. Let's go. Cindy, do you have any thoughts?
Well, first off, amen to Abner. I if I could give you like 10 thumbs up, I would, because that is such a true statement. And I think that as the federal government and as we look at policies, with COVID, a lot of things, telehealth in every state exploded on a dime. We all went from doing this much telehealth to a great telehealth for everything. And if the pandemic didn't push us, we probably wouldn't have done it. We would probably still be talking about maybe using telehealth for certain areas. So it can be done. And, and if we can do it for unwinding, why can't you do text messaging for other things? So definitely concur with Abner there. But I think the other areas that we do have to, especially in West Virginia, which is a rural state, that we have to be kind of cognizant of. There are areas in our state where we really do not have broadband. We really do not have the ability for even text messaging. That needs to be worked on as a country for our rural areas. That's one area that is definitely a barrier. The other barrier is something that I think Mick really helped us with, state staff and definitely Medicaid staff around the nation. There's a lot being thrown at us at once. And so we really don't have the time to go and say, like, here are the 10 best tech-enabled solutions for this issue that you're having. So having a collaborative like Mick, or being able to talk to other states about, like, this is what we're using and this is what's really working with our members, is something that really can help you get through that barrier of not having the bandwidth to basically push it along. So those are kind of the main barriers, but I could listen to Abner all day talk about those regulation barriers. I feel you.
Thank you. And Heidi, want to give you a chance to weigh in here as well.
Sure. Yes, I too, Abner, very thumbs up. I'm facing that challenge right now with the unwinding, so I hear you. And to Cindy, to your point, Banner Health Plan, we serve some of the most rural areas in Arizona where there is, and tribal communities where there is no internet in some of those areas. So really looking at tech solutions that have low bandwidth, low storage in some of the areas that are challenged with some internet bandwidth issues. And then one other thing is what we found very helpful when we're talking to providers about a possible solution is really bringing the provider community together. We hold community forums where we bring them together and really talk through the solution and present it in a way that we do not want to create another workflow for providers. We do not want to burden their current workflow, but really this solution is an add-on. It can go right into their EHR. It doesn't intercede or interfere with their current workflow. So really trying to bring providers to the forefront, hearing the challenges, and also working together to really understand that this is not an added burden. Again, this is a solution to help them. So that's some of the things that we have brought through community forums to really bring some of this forward.
Great, thank you everyone. So I see we have a very active Q&A. So with that, I think I'll just start moving to audience questions, because I want to make sure we get through at least a few here. So give me a second while I pull this up. And the first question that came in, it looks like it's one for Cindy. So the question asks or notes, West Virginia Medicaid is the first in the nation to fund smartphone-based motivational incentives for stimulant use disorder patients. So first, Cindy, I think would be, if you're able, would be great if you could speak just a little bit to that effort. And then the question itself is, how important is capturing behavioral and physiologic data and aligning that with claims utilization? Curious if you have any thoughts on that.
Well, important. I'm just going to talk in generalities for all of our tech-enabled solutions. What's most important is once you do a tech-enabled solution, and as we're looking at evaluating our program, is did it do what it said it was going to do? Is it moving the needle? Is it doing? And so in order to do that, you're going to have a way to capture that, whether it be through claims data, utilization data, or actually, if it's moved the needle a lot and you have a lot of participants, you can actually see better health outcomes, which is the ultimate goal, right? So, with regards to this project and any project, the data really needs to be there. You have to be able to evaluate what you're doing and make sure that it is not only doing what they've sold you it's going to do, right, but it's actually helping your members, and that's the ultimate goal.
Thank you, Cindy. So this next question, I'll ask it and see if anyone has thoughts. It's a little more technical of a question, and if not, that's fine. So the question is, how are you addressing race and ethnicity discrimination and bias in tech-enabled solutions? Often data or algorithms used to build these solutions are not developed with health equity in mind. So curious if anyone has thoughts, and I think perhaps as an addendum to that question, if anyone has thoughts on how to really build health equity from like the beginning into the design of or implementation of tech solutions. Anyone have thoughts?
Well, I'll just share that we have some experience with that, and what we have found is key to. First of all, we need to have some humility that our country, has a lot of bias that we've lived with for a long time as we've been on the journey as a country to become more equitable and more just. So we're not going to fix it overnight. So we need to have some humility and recognize that we all carry some of that bias with us. We try to be, people of good, just good people with good hearts, but we have bias because we've grown up in this society. And so what we found is that we've got to test for that. We've got to build our solution with the idea that we need to be A/B testing and testing at every turn to make sure that we're not building in bias. And there are tools to do that. There are strategies to do that. So I think the key here, and I guess I don't want to repeat myself, but the key is having the humility to know that probably you have some bias and that you need to have an intentional strategy to ferret out that bias, to look for it. And sometimes bias hides, it's sneaky and it feels natural, but it's not. It actually is bias that we've lived with so long that it feels natural. And so from our perspective, you got to have an intentional strategy when you're building from scratch to make sure that you are looking for that kind of bias. And the other thing that helps is frankly having bringing some diversity to your team so that you have people with some different perspectives and lived experiences. We've done that at our organization. I'd encourage others because one thing that can help is bringing people who don't think like you, because it's very humbling to have a team that's diverse, because all of a sudden you're going to have people who are bringing perspectives that are different from your own. So I think key to this is recognizing that we all have bias, no matter what we look like or where we come from, we have some bias, and we need an intentional strategy in order to make sure that we aren't building that bias into our solutions.
Thank you. Thanks for that perspective. So I have another question here. This one's for Heidi. When implementing new tools, such as the PIC solution that you mentioned earlier in our session, how is awareness approached in terms of, I think the question here is about making members aware that solution or opportunity is available?
Yeah, so some of the solutions that we've done is it's well, one of the nice things besides Banner as an insurance, as an MCO for Arizona, we also have a healthcare delivery system here in Arizona. So we have physician groups, we have specialist groups, we have hospital systems. So really for us, it was widespread out to all of the Banner system of delivery to really get that word out within their clinics, within their practices, within the hospitals upon discharge. When we discharge anybody out of any of our out of not just Banner 2, we've extended that to other hospitals, but when somebody is coming out on discharge, they are getting the information on how to get on PICS. If they need technical assistance, PICS will reach out to them, help them get that app on their phone. And other than that, it's really member onboarding as they become new members on the health plan, is really orientation, and through, again, snail mail, which is not the best, right, Abner? But those are some of the options that we have. And then the member handbook and various newsletters is how we've really gotten the word out. But I think our provider network is one of the largest ones to ensure that they get that information out to the members since they're doing member-facing activities.
Great, thank you. So let's see. Another question, and again, I'm not sure who might answer this, but I'll ask it and see if anyone has thoughts. When implementing tech-enabled solutions, how do you address, or I guess, what are some options for addressing potential barriers to low digital literacy among users? I think to some extent, Abner, you maybe started getting at, not this exact question, but kind of a broader perspective about thinking about health equity and early design of solutions.
Yeah, I think that, so just my perspective here, I think there's an interesting irony that we have to live with. On the one hand, one of the reasons that the Medicaid Innovation Collaborative exists and why I think it's so important is that we need to find ways to scale tech-enabled solutions across Medicaid. Unlike Medicare Advantage and commercial, Medicaid is state by state. There's that old saying, if you know one Medicaid state, you know one Medicaid state. You got 49 others plus the territories to figure out. There's, it's not one market. It's all these mini markets, and that makes it very hard for entrepreneurs. People like me who have tech-enabled companies. We are deep in Medicaid, but a lot of entrepreneurs are like, that's too complicated. Let me deal with commercial, where it's a national solution, or Medicare Advantage, where it's a national solution. I don't have to go state by state, and the margins are better in Medicaid and commercial. You can make more money because the margins are better than Medicaid. So the irony, so on the one hand, that makes it difficult for tech-enabled solutions to scale in Medicaid. And again, that's why, MIC is so important. But on the other hand, if you are an entrepreneur and you're building a solution, you're better off building it for a Medicaid market. Because think about it, if you build a solution that works for low income, low health literacy, folks who struggle, it's going to be much easier to take that solution and take it upscale to commercial and Medicare Advantage. You can add bells and whistles and make it look prettier and charge more for it. But if you built it for the hardest to reach people, it's going to be easier to scale that solution to easier to reach people. So there is this irony that on the one hand, entrepreneurs and investors say Medicaid isn't the place, but on the other hand, I would argue it is the place that you want to sort of build for. So in terms of how you do it, I think one of the key things is when you're building for a Medicaid market, you need to really stay connected to the member, meaning talk to people, talk to members, and meet them where they are. And that's what I mean by building a user interface that's designed for people who don't have, all the times the highest, digital literacy. They struggle to connect. They have bandwidth problems. They have, so if you build your solution to meet the needs of folks who are on Medicaid, first, it's a huge market. So there's a huge market there. But secondly, from an investor and entrepreneur perspective, if it works in Medicaid, I guarantee you it'll work as you add bells and whistles and make it, appropriate for markets with more margin. So that's my thought.
Thank you so much. Kind of going off of that idea, as well as a bunch of questions I'm seeing about design and centering health equity. I think a really important piece of all this that, again, I think you alluded to is really working with members to identify their needs and address member priorities. So I want to dig into that a little bit. Perhaps maybe jumping to you, Heidi, would really love to hear about in your work how your organizations worked with Medicaid members to inform your strategy around tech solutions.
Absolutely. Thank you. Yeah, so that is key, is to get that, the lived experience, the member feedback on digital solutions. So within Banner University Health Plan, we do have we call Office of Individual and Family Affairs Department, and those are folks that have lived experience. They are employees within the health plan. So bringing that to within any processes or anything that we do within our organization is key, working with our members as well. And then one of the other things that we also have is what we call a member advisory council. And that is made up of our members who are on our health plan or family members. And really we bring those types of things to that council to really vet it out, to have them take a look at it. What do they think? Would this work for them? We pretty much do any of member facing materials are really brought to that council to get feedback on, does this even make sense? Is somebody even going to look at this? And especially what's key right now is during the unwinding, we're really bringing that information that is a standing topic on our councils to really understand, is our unwinding plan going to reach who we think it's going to reach? Or, what other ways can we reach our members? If it's not via text or robocalls, what are some other ways to do that? As well as we developed neighborhood advisory councils as well. And so we have about 15 of them throughout the counties that we serve. And so that's bringing the community members, partners, providers to the table to really understand what's going on in that community that they live in. And what are some of the barriers and how can we work together to address some of those issues? So those are some of the ways that we definitely ensure that we have member voice and choice in a lot of what we do within the health plan.
Great, thank you. I'd love to pose a similar or a related question to Cindy too. So as context for this question, a key aspect of the MIC initiative was research on member experience to inform tech solution identification. So Cindy, I would love to hear what you learned from this work and how member perspectives inform your thinking about tech innovation or quality strategies more broadly for Medicaid.
A couple things. So one of the things that the MIT cohort did, they really went out there, talked to members in Southern West Virginia, Northern West Virginia, and if you're from West Virginia, Southern West Virginia looks far different than Northern West Virginia, right? And so so it was an interesting perspective because West Virginia Medicaid has a very large footprint in our state. Our state's about 1.8 million total. West Virginia is covering 635,000 of those citizens. But a lot of people in West Virginia, we have a very significant Appalachia culture, and we don't necessarily want to say that, I get this from Medicaid or I'm on the Medicaid program. We definitely are a pull yourself up by your bootstraps type of a culture. And so on a tech-enabled solution and things like that, I think one of the things that we were looking at is, they want these solutions, and I think it's good for them to have these solutions, and they're about using some of the solutions, but not necessarily labeling it because I'm on the Medicaid program. That it is a program for anybody in West Virginia that can use this program. And so that was one of the stigma things that we really wanted to make sure that when we do tech enabled solutions, that whatever we do is we're not buying into that stigma of the concern of some of our members of being on a Medicaid program.
Thank you so much, Cindy. Going back to our audience chat here, we have a question about either general practices and best principles or possibly examples about how tech can be leveraged to connect folks with community-based organizations and support integrated care. I think a number of you spoke to this a little earlier in our discussion, but wanted to see if anyone has additional thoughts on opportunities for tech there.
I'll happily chime in. I think one of the areas that is exciting and encouraging is that for a long time we've known that a person's health care is not primarily a reflection of what happens in a clinical setting. We know that the social determinants of health and stuff outside of the clinical setting have a profound impact on health. Some people say, 60, 70, 80% of your health is more a reflection of those other factors versus the narrow clinical setting. And so there's been a push to address the social determinants of health. A lot of us, and I think folks in this panel agree, most of those needs are best addressed not by medicalizing them and trying to push it into the clinical context, but instead to use community-based groups who are set up in the community. They're passionate about it. They know how to address hunger and domestic violence and other kinds of issues that people face. But it's been hard to figure out how to pay them for their services. A lot of those CBOs, community-based organizations, live hand to mouth. They have enough money to pay the bills for this month or next month, and that's it. And so we need to figure, if we're going to depend on them to address these issues, we need to provide some dependable funding for those community-based groups. And I think tech-enabled services are coming to the rescue here. There are many companies, but two that come to mind. One is Find Help. It used to be called Aunt Bertha, and I think Unite Us is another one that we actually know well. They are building the capacity to organize the community-based groups and to allow for them to get funded for the work they're doing using technology, because it's just hard for big institutions or even the state of Virginia to pay these little groups, but you can use technology to do it. So I think that this is another example of where tech-enabled services is coming to the fore and is offering solutions that could really help us going forward.
Great. Well, thank you so much for that.
I'd like to
build on that.
piggyback off of Abner. Yeah, Unite Us is, sorry, Cindy. Unite Us is big in Arizona. They're working with our HIE to do that closed loop referral system. And I think that's key to know that you didn't just refer somebody to someplace, it's actually that action took place. So that information can come back to whoever made that referral, that referral was taken care of, that member got connected, so that so that if the member didn't get connected for whatever reason, you can go back and ensure that what happened and start from scratch again if needed be, but really knowing that was addressed versus just saying I referred a person. So I think that closed loop referral system that a lot of states are moving to is key too.
Yeah, and this totally agree with Heidi and Abner. We all of our MCOs here in West Virginia use Find Help, and I was actually just speaking at a value-based purchasing conference yesterday in West Virginia, and one of the things we were talking about is with value-based and different things that you're doing out there that is kind of innovative and really addressing those social determinants of health. We want that data. We want to know how is it addressing, and the CBOs a lot of times have, they're not going to know how to do a 1500 or a UB form for a claim, right? But how are we going to get that data to know what's happening out there, so we can have the information we need, so we can know, okay, here, this county in West Virginia, their social determinant, it really is food insecurity over here. This is where we really need to focus over here, but maybe over here in northern West Virginia, it's really a housing need, or, and in order to get that information, we really want to work with those CBOs and really train our MCOs to collect that data in a way that we can really start honing in on these areas, whether it be with, the tech-enabled solution, which is definitely going to help us, but using that tech-enabled solution to bring that data to us is a very important piece of this.
Yeah, thanks for all those thoughts. So we're reaching the end of our time here. So what I'd love to do is just have a really, really quick kind of rapid fire round robin with all of you about, is there just one final takeaway you want to communicate to the group, or perhaps a piece of advice to a peer organization? I'll start with Abner.
Sure. So my key takeaway I'd like to share is that one size fits all isn't going to work anymore. That used to work. Actually, it never worked that well in healthcare, but it definitely doesn't work going forward. Patients and health plan members expect better and they're demanding better. And so I'd encourage you to get away from the one size fits all. Let's create personalized, customized, experiences for patients and members. That's what we're doing at Same Sky Health. Happy to talk to you about it. But that's, I think, key to building trust and to engaging people and to achieving a lot of the other, to the goals we have for healthcare.
Let's see, Heidi.
Sure. One thing really quick that I think needs to be vetted out is, some of these tech solutions cost money. Some of our providers, our small providers or rural communities don't have the money to invest in these. So I think states and MCOs need to come together and think about how we can invest some money into this or incentivize, or, there are funding out there, but it may be restricted funding, right? Our community reinvestment is restricted on various things that we can use it for. So I think coming together and really finding solutions on some of the costs for some of these is another opportunity.
Cindy.
I think the biggest opportunity is just to get started. If you haven't started, start with something, because you'll be amazed about what the return on investment is. And at the end of the day, what actuaries look at, what CMS looks at, is they're going to look at that ROI. Are you producing those health outcomes? And if you are, then we're going to figure out a way to fund it. So.
Right. Well, again, thank you so much, everyone, for joining. This is a great conversation. But alas, I have to let you all go. So I'm going to give, feel free to go off camera. And Travis, yes, thank you for pulling up our wrap-up slide here. And I did, before I kind of go into this, I did see in the chat, someone had a question about, is there a second cohort for MIC? And there is. So Carissa, if you wouldn't mind just popping on and giving a little overview.
Yeah, absolutely. So we are very excited to officially launch our 2023 cohort very, very soon. We have commitment from 3 state Medicaid agencies so far, and there is a little bit of time if your state is interested in participating to reach out to us. You can reach me directly at carissa@medicaidcollaborative.org if you have any follow-up questions. But for the focus of that cohort, our first cohort, we focused on behavioral health. As Cindy mentioned, we had some states focus on adolescent behavioral health and some focus on maternal behavioral health. For the second cohort, we are really excited to pursue what is the very large umbrella of social determinants of health, and looking forward to collaborating with our states and their managed care partners and community members on tackling that complex but very worthwhile issue. So.
Great. Thanks, Carissa. And so, again, on the slide here, that second part, we have links both to the MIC website if you want to learn more about that first cohort, or again, you can reach out to Carissa or I, our emails are there if you want to learn more about cohort 2. And the final thing that I'll mention is that we also recently published a brief about policy opportunities and considerations for supporting tech through Medicaid managed care. So I also have that linked on the previous slide if anyone wants to learn more. So with that, thank you everyone for joining our event, and I hope you have a great afternoon.